So we're going to be speaking about differential diagnosis. This should be the last time we have to do it formally. It's obviously going to come up a lot more over the coming months, but this is the last lecture, if you like, on it. We'll be looking at what it is, how you do it, why you do it, and its value both in a number of different cases. So differential diagnosis is a process of separating two or more conditions, all of which could cause a patient's symptoms. You can actually use differential diagnosis as a method of making a diagnosis. You see this on House, a TV show. The patient has some symptoms, they'll come up with a list of differential diagnoses, and they'll run appropriate blood tests and imaging for each one, and they'll see which one is positive. It doesn't work that way in the program, because what he does is he's got no idea what's going on, and he has an epiphany because he sees somebody walk past funny. But it's a very cumbersome way of making a diagnosis. No real hypothesis, just list the things that could cause it, test each one. The other way to do it is hypothetic inference or abduction, or incorrectly deduction. And what we've been talking about is strict focus hypothetic inference. And you use the differential diagnosis to generate the hypothesis. So the patient gives you a symptom, and you've got a patient profile, you know what they look like, you know how old they are, what sex they are, and you immediately generate a hypothesis based on presentation and where the pain is. And then you basically test that hypothesis by asking a series of questions and tests, and you either refute the hypothesis, in which case you get a second hypothesis, or it works and you've now got your diagnosis. If you cut the size of the questions and tests down to the minimum needed to make the diagnosis, then this becomes strict focus hypothetic inference, and you use the essential illness script to test the hypothesis. Differential diagnosis can also be used to correct bias and error. So once you've made the diagnosis and you accept that there might be confirmation or availability bias or anchoring or whatever, then you can list a number of differential diagnoses and then compare them to the patient's complaints and make sure you haven't, and to your diagnosis, and make sure that you haven't been prone to bias or making an error. And then, of course, the usual use of it is to check your diagnosis against other possible diagnoses in the form of differential diagnoses. So which ones seem to fit the patient's complaints better than your one? If you can find that, then you go with a differential. How do you do it? How do you generate the differential diagnosis, and how do you use it? Well, you generate the differential diagnosis by looking at similarities between potential diagnoses that could cause a patient's symptoms, or the hypothesis that you want to generate. But they have to be similar to your diagnosis or hypothesis. It's no good if they're miles out, there's no overlap, they're not of any value to you at all. And this is completely different from the way you've probably been taught, which is you make the diagnosis and list all of the things that could cause pain in that area, and that's of no value. It's got to be similar to the diagnosis that you've made, or it's of no value at all. You can do it with completely dissimilar differential diagnoses, but this is normally done when you really don't have any faith at all in your diagnosis, and you'll make sure it's not something outlandish. So you use similarities to generate the differential diagnosis, and you use differences to separate them apart. So that's how you generate it, and that's how you use it. Okay, so we'll look at a simple example, a straightforward case of the processes involved. So you have immediate information from the patient. You've got their sex, their age, and where the pain is. This will generate a hypothesis that you can test, and you use the essential illness script for that hypothesis to attack your hypothesis. In this case, it fits, so you move on to bias correction, and that's where you use the differential diagnosis. You run through each differential diagnosis, mentally and physically with the patient. And if you're thinking there's something, and you've got a test that is very sensitive for that, you can run the test. If that test is positive, then you can start using more specific tests on it. So you're actually going to test the hypothesis if you have to against yours. Generally speaking, you can rule it out fairly quickly because something in the patient's history doesn't work, or a test you try on the differential doesn't work. If you find there is no bias and you're still stuck with your diagnosis, then H1 actually does become a diagnosis. So this is a straightforward case, and this is most of your patients. If you think about it and you do this right, most of your patients are fairly straightforward. Let's look at an example then. We've got a 65-year-old male complaining of central and bilateral low back aching. The obvious one to think about is based on the age, the sex of the patient, and the area of the pain, and even the type of pain. So you come up with central stenosis. You don't, I'm going to say this now because there's a misunderstanding here. You do not need leg pain to make the diagnosis of central stenosis. Leg pain comes on as the stenosis gets worse, but not in the initial phase of it generally. So we've got an essential illness script for it. We use it. So the complaints are ache with extension activities, the threes relieved with flexion activities, range of movement, extension is limited with mild central pain, lumbar PAs are stiff and mildly painful. All of that is fine. So we now have a provisional diagnosis of central stenosis. So why not? That's your question. Why isn't it this? It may be bias. So we've got familiarity, confirmation, anchoring, premature closure. Premature closure, complete the exam. If you really think this is an issue, complete the exam, and we'll go down that line a little bit later on. Otherwise, you generate a bunch of differential diagnoses. Now, the ones for central stenosis that I would use for central stenosis are degenerative spondylolisthesis, contained disc herniation, pathological fracture or tumors, atypical segmental dysfunction. But you can use any ones that have overlap with central stenosis. So we look at these against the presented symptoms and signs, and we can also attack it with other tests if we want to, if we can. So the first one, degenerative spondylolisthesis, is a little bit too old for the first episode, and the end feel was stiff, and that's not what you get with central stenosis. It's not stiff end feel. It can be a lot of things, but it's not generally a stiff end feel. Contained disc herniation, all of the movements are painful, not just extension, so it's not going to be that. Your PA on that is not going to be stiff, it's going to be extremely painful, so it's not that. Also, the age is wrong. These contained disc herniations occur in 28, 30-year-olds. With pathological fractures, flexion is going to be your real problem. You're not going to be able to sit happily, you're not going to be able to bend over happily, because you shift your weight onto the anterior column, and that's where the pathology lies. Extension may well be painful, but it's dominated by flexion. And the last one, atypical segmental dysfunction. The end feels completely wrong, and pretty much everything else about this is wrong. The age for the first episode and so on. If you've completed the exam and you're fine with that, there's no change, then you can go to basically to the diagnosis as it stands. If there is a change, go into the differential diagnoses, test them out again, and then change the diagnosis if you need to. So this is a fairly straightforward process, and it doesn't take very long on most of the patients who come into your clinic. Well, let's look at a somewhat less simple example then. We've got same immediate information. Sex, age, areas of pain. You've got the same information. You generate the H1, you attack it with the illness script for H1, and it doesn't fit. So you move on to H2. But now H2 is the best fit from your immediate information and the information you generated when you was testing H1. So you've got more information that you can use now. If that doesn't fit, then you move on to H3, and now you've got even more information to help you, and you're focused on each hypothesis as you go, so you're not getting overwhelmed with information. And if that doesn't work, then H4, HN, and so on, until eventually you do this right, and it does fit, then you can do, there's no bias now. After doing enough of this, you can eliminate bias. In fact, a lot of the biases are eliminated the first time you say, oh, my hypothesis doesn't work. That gets rid of availability, confirmation, familiarity, all of the stuff that you really worry about, you've got rid of. And on top of that, the more of these hypotheses you test, the less risk there is of premature closure. So that's a somewhat less simple example where the first hypothesis doesn't work. So let's have a look at this now with a new set of information. This is a 40-year-old male now. He's complaining of central and bilateral low back ache. Now, central stenosis doesn't really work terribly well here because, I'm sorry, I'm being distracted by my picture behind me. I meant to take it off before we put it on. We'll all have to live with it. Sorry, there's two of me. So you're not thinking of central stenosis because of his age. So probably the next best one will be degenerative spondylolisthesis. And there's a reason for this. They are both stenotic problems. Central stenosis and spondylolisthesis both end up causing central stenosis. So the reason for H1 now is the area of the pain again and the age of the patient again. Now, what we find when we look at H1's illness script is it gets aching with extensive activities, it's relieved by flexion, range of motion is extension is limited with a central ache, lumbar PA stiff and mildly painful, and there's no step deformity now because that's going to be in that illness script to some extent. Not all of these develop a step deformity, and some of the degenerative ones don't very much. But if it's present, it's fairly specific for a spondylolisthesis being. It doesn't mean to say that spondylolisthesis is the source of the symptoms, but it is saying there's a spondylolisthesis there. But he doesn't have that, which mildly argues against it being a spondylolisthesis. But the big thing is flexion is going to hurt a spondylolisthesis because when you flex, you drive it even further forward. It's certainly not going to help it. In this case, though, flexion activities do help. Kyphosin might, but not flexion. So H1 is wrong, all right? I think it's reasonable to say this is probably not spondylolisthesis. So, as we say, it's relieved by flexion helping, or not helping, and also the lack of step deformity. Also, the infield's wrong. Again, we've still got that mild, stiff and painful infield on PAs. So is there a bias? No, because again, your first hypothesis is wrong. It tends to throw out all of the possible biases. So we move to a differential diagnosis now. Now, central stenosis is probably the leading differential. Contained disc herniation, pathological fractures, atypical segment dysfunction. It's not 2, 3, and 4 because we've already dealt with those with exactly the same symptoms. It leaves you central stenosis. So what we need to do is figure out why a 40-year-old man would have a central stenosis. Two main reasons. There may have been a fracture years ago, excess callus formation basically causes a stenosis, or he's got a congenital narrowing of that spinal canal, or a trefoil-shaped canal where it's like pinched in on the corners. It's almost triangular, it's three-leafed. So all of those can give you early central stenosis. Are there any known biases or unknown errors? Known or unknown biases or errors? Any differential diagnosis is a better fit than central stenosis. And if not, then it has to be your diagnosis. If yes, test that other differential diagnosis. And that's it. You can always be wrong. And you can only test the diagnosis by treating it and getting a good result with the treatment, but even that doesn't definitively prove the diagnosis. But that's all you can do. You're in a clinic, for God's sake. You're not doing research. You haven't got a number of variables that you can select to stay the same. You just can't do this. So this is in your clinic. You make the best fit that you can for the diagnosis. And in this case, I would argue that central stenosis is a best fit, simply because the previous case was okay for central stenosis and the symptoms are exactly the same as the previous case. That's your experience coming in now. I know that my previous cases looked like that, this one looked like that. So unless I can find a reason for it not to be that, then that's what it is. Good God, we got rid of that picture. Okay, so that's it. If you've got any questions on differentials, then email me and I'll be more than happy to talk to you about it. I'm going to give you some exercises that will start looking at connections, and differential diagnosis is about connections. So we're going to be doing exercises to make you think a little bit more in that way. All right, so take care, everybody, and I'll talk to you again soon. Bye-bye.